Hello out there. Good to see you. Now, we're going to talk about locating the lesion. Neurology is no easy subject, believe me, and we're going to try to do neural pathophysiology in like 5 minutes. Hang in there. We'll work at it together. Let's look at what's on the screen. The motor homunculus. I'm talking about the part of the drawing on the right-hand side. You notice that the brain is broken up into lobes. Anterior lobe here. Here's the temporal lobe, looks like a little tongue sticking out there, and parietal lobe, occipital lobe in the back. Now, right in the split, if you will, between the frontal and parietal lobe is the motor homunculus, the area that takes care of the muscles of our body, face, arms, and legs. Now, you'll notice that the brain, this is a slice of the brain. We've cut the brain in half. And so you're looking at the areas that control this part of the body. You notice at top the leg is draped over the cortex. It's because the anterior cerebral artery perfuses the leg. Then you notice, look at that huge hand and that big old mouth. Whoa, does that remind us that, boy, he who guards his lips guards his life. God wasn't kidding about that. But this is Broca's area, that verbal motor response area. That's so important for our ability to communicate on that left or dominant hemisphere. The middle cerebral artery perfuses both the hand and the face and the arm. So the motor homunculus of the cortex is really important to get in your mind, and that's why I've put that picture up there for you. Number one, the motor homunculus. Number two, you've got to know the difference between the lower motor neurons and the upper motor neurons. The upper motor neurons come from brain down the brain stem into the spinal cord, and then synapse in the lower motor neurons and the anterior horn cells there at the spinal cord. Upper motor neuron lesions present with hyperreflexia, a spastic weakness, versus lower motor neurons. Those come from that anterior horn cell out to the periphery and attach to the muscle. When they're injured, they cause a flaccid weakness and hyporeflexia. You try that biceps reflex and nothing happens. Upper motor, lower motor. Upper motor, lower motor. Okay? Gives some idea of the difference between those two. The motor homunculus, upper motor neuron versus lower motor neuron. And finally, let's take just a quick gander at the spinal cord itself. This is anterior and this is posterior. And there's the cord smack right in the middle. Remember now the cord has tracks running from the brain to the muscle, the cortical spinal tracts, and sensory tracks running from the periphery to the brain, the spinal thalamic tracts, and those things crisscross at different places. So you realize if you cut or damage anything in that spinal cord, you're going to have abnormalities on both sides. Just to give you some idea, again, here's the vertebral body. This is where the intervertebral disc would sit, and there's the cord right there, that juicy cord protected by bone on both sides. Okay, with that in mind, let's now go to locate the lesion. Typically, we're talking about patients who've had strokes. And this is something that you'll deal with in the office and move people out of the office to the emergency room. But you want to have some idea what you're talking about, where the lesions are. Okay, this wonderful lettuce leaf, this is the cortex. Okay, the higher level functionings of thinking. There it is. Okay, that's the cortex. Underneath the cortex, the potato, the subcortical area. Gray matter. We'll have a little snack later. White matter. And then below that, there's the brain stem, also known as celery, and the cerebellum, which loves to deal with motor coordination. Okay, so there's our little friend. Now, the first question to ask is the neurologic deficit unilateral? Is it on one side? Just one side? Of course, you're going to have to do a good neurologic evaluation, a good neurologic exam to be able to tell that. If it's just unilateral, it has to be either in the cortex, the subcortical area, or a spinal or peripheral nerve. It can't be the brainstem or the cerebellum. That would be very unusual. Okay? So We're limiting ourselves here at this point to the cortex or the subcortical area or the spinal nerve or peripheral nerve. Now, the next question is it a lower motor neuron abnormality? Meaning, is the weakness somewhat flaccid and are the reflexes down? Reflexes down. If it's a lower motor neuron abnormality, then you know that it either has to be in the spinal cord or one of the peripheral nerves. Okay, either the spinal nerve root, what we'd call a radiculopathy, or peripheral nerve root, or peripheral neuropathy. Okay? Next question. Is the weakness in the face and the arm and the leg identical? Is the weakness in the arm and the face and the leg identical? And remember, with motor weakness, we use 5/5 as normal. 4/5 meaning they can resist somewhat against resistance, push somewhat against resistance, but not a full resistance like a 5/5. 3/5 means they can move just against gravity, no resistance. 2/5 means they can move the arm, but not against gravity. And 1/5 means nothing but little fasciculations or fibrillations that are best seen on nerve conduction studies. Okay. Next question. So, is the weakness of the face and the arm and the leg the same? Then the lesion has to be in the subcortical area. It can't be in the cortex. We saw the motor homunculus. There's no way. You'd have to tear out all of the anterior cerebral and middle cerebral artery area. So something that has face and arm and leg equal has to be a small lesion deep in the subcortical area. We call lacunar strokes. Those are typically seen in diabetics or hypertensives who are not under good control. And it's kind of it's called a lipohyalinosis, a meltdown of the small penetrating arteries. Subcortical. So if it's equal, look in the subcortex or the lacunar area. The next question is there loss of higher functions, cerebral functions, functions such as language or stereotaxis, the ability to put a quarter in the hand and say, oh, that's a quarter, or a pen and say, ah, that's a pen, or to draw a clock face, or to be able to show how you brush your teeth. Those are higher level or cerebral functions. And so if there's a loss of those higher level functions, then you know that it's in the cerebral area or the cortex. Okay? If there's muscle incoordination, look to the cerebellum, such as dysmetria. This side's good. This side can't get to that nose, dysmetria, or dysdiadokinesis. The rapid alternating movements are normal here, but on this side, they're very uncoordinated. Okay? Those are signs of cerebellar abnormalities. Now, the next question, is the deficit bilateral? If it's bilateral, it's got to be either in the brainstem or in the spinal cord itself. We looked at that spinal cord. You can't just slice a lesion without getting, or make a lesion in the spinal cord without getting deficits on both sides. The same in the brainstem. There's so many pathways crisscrossing in there that if a stroke or a tumor trauma in the brainstem is going to cause lesions on both sides. Now, is there cranial nerve involvement? Cranial nerves. 1, the olfactory. 2, the vision. 3, 4, and 6, the extraocular motion. Of course, 5 is face sensory. 7 is the motor, ocular motor, the motor features of the face. 8, the acoustic nerve for hearing and balance. 9, the glossopharyngeal. 10, the vagus, same thing, helps with swallowing. Of course, the diaphragm too. The 11, the accessory nerve, okay, which helps with the sternocleidomastoid, movement of the head and neck. And 12, the hypoglossal. Is there cranial nerve involvement? Then you know the lesion is in the brainstem. Is there weakness on one side and sensory loss on the other? It's got to be in the spinal cord. So this is a little, just an intro to locate the lesion. Is it cortical, subcortical, brainstem, cerebellar, spinal cord, spinal nerve, peripheral nerve? We'll talk some more, work on that, and remember, this is the day the Lord has made. Let us rejoice and be glad in it. Psalm 118:24. Dr. Leibert, talk to you later.